Thank you very much for the kind introduction. I'm going to talk to you today about functioning pancreatic neuroendocrine tumors. It's an interesting topic, and I'm excited that the crowdsourcing agenda showed that you wanted to hear about this. So a little bit of a background for you to know. To understand functioning pancreatic neuroendocrine tumors, we need to understand a little bit about the pancreas. The pancreas is an organ that sits behind your stomach and below your liver. It's in the back of your abdomen. Not that easy to get to, but we can get to it if we need to do surgery. There's two important things you need to know about the pancreas. Number one, pancreas cells can produce juices that help you digest food. That's called the exocrine pancreatic function. And then there are these purple cells here on the graph that are called the islet of Langerhans. They are cells that are distributed throughout the pancreas. They are important because they secrete hormones that do a whole bunch of things in your body. One of the common and most known hormone that these cells secrete is insulin. Pancreatic neuroendocrine tumors, as you know, represent about 5 to 10% of all pancreatic malignancies, meaning when you do have a pancreatic neuroendocrine tumor, it's a little bit rarer tumor than the classic adenocarcinoma of the pancreas. They should not be confused with one another. They do derive from this islet of Langerhans, which I just showed you before. These islets are distributed throughout the pancreas. About 7% of all newly diagnosed neuroendocrine tumors are pancreatic neuroendocrine tumors. So that represents an incidence of 3.3 per million per year. And as you can see here in the chart on the right side, the blue curve shows that the incidence is slowly growing. About 10 to 30% of these tumors are functioning neuroendocrine tumors. It's kind of unclear exactly what the actual percentage is. I think it varies a little bit depending on where you are and how many patients you see with this disease. My personal experience is that it's closer to the 10% or less. So you could just remember that a majority of these tumors, or even a vast majority of these tumors, are non-functioning pancreatic neuroendocrine tumors. And by non-functioning, I'll tell you what that means. I mean that they're not secreting hormones that are causing clinical symptoms. And sometimes functioning and non-functioning pNETs can be associated with rare genetic syndromes such as VHL and MEN1. Two prominent people that unfortunately passed away of, as far as we know, non-functioning pancreatic neuroendocrine tumors are Steve Job and Aretha Franklin, but they both lived a long life with these tumors. Now, we're here to talk about functioning pancreatic neuroendocrine tumors, so I'm coming back to this little islet of Langerhans. As you can see on the right side, there's different types of cells within the islet of Langerhans. You can see here some cells are purple, some cells are yellow, some cells are white, and essentially these different types of cells secrete different types of hormones that we normally need to function as a human being. And this is an important table that will basically show you a lot of the things that you need to know, but essentially depending on what type of cell you're looking at, for example, the beta cell is the cell that secretes insulin. So if you have a functioning pancreatic neuroendocrine tumor, meaning a tumor that originates from one of these cells, then you would have a insulin-producing tumor, which is called an insulinoma. And we'll go about all the symptoms of each one of these tumors in the next few slides. What's important, I think, to remember is that the two most common functioning neuroendocrine tumors are the insulinoma and the gastrinoma. Now, the gastrinoma is not part of this table here, so I added it just below. The reason for that is that the gastrinoma can originate within the pancreas, but doesn't have to originate within the pancreas. It can also come from the duodenum, which is the first part of the small intestine, or from the bile duct. Now, the prognosis of functioning pancreatic neuroendocrine tumors. So the first graph here, and you probably noticed by now, what's in red is the prognosis or the survival adenocarcinomas of the pancreas, which I mentioned again one more time are different than neuroendocrine tumors of the pancreas. The blue line shows the survival of neuroendocrine tumors of the pancreas, and you can see you will live a lot longer, do a lot better when you have a pNET than when you have a classic adenocarcinoma. Whether functioning pancreatic neuroendocrine tumors have a better or worse prognosis than non-functioning pancreatic neuroendocrine tumor is still a little bit debatable. There are some studies that have shown that functioning pancreatic neuroendocrine tumors may have a better prognosis, but I didn't put up these graphs there because I'm not confident that we really know exactly which one has a better prognosis or whether they're pretty much equal. You should know that, like any other tumors, survival of functioning and non-functioning pancreatic neuroendocrine tumors depends on the stage. So if your tumor has metastasized, your survival decreases than if it has not. And this is a study that I looked at a couple of years ago, but essentially we looked at all functioning pancreatic neuroendocrine tumors that were malignant, so they had spread. And if you look at the survival there really is no major difference between the subtypes. So it's not like, because you have a VIPoma that has metastasized, you necessarily will do worse than when you have a gastrinoma or glucagonoma. Those are pretty much equal in terms of long-term survival. Now, this is what I wanted to explain to you before, and I'll talk to you about that in detail now. All pancreatic neuroendocrine tumors have the capabilities to secrete hormones or biomarkers. So these hormones or biomarkers can be chromogranin A, pancreastatin, pancreatic polypeptides. These, however, do not define a pancreatic neuroendocrine tumor as being functioning or non-functioning. As a matter of fact, these hormones on their own do not cause any symptoms. And therefore, you could have a non-functioning pancreatic neuroendocrine tumor with a high chromogranin A level. It's not because you have a high chromogranin A level that this is a functioning pancreatic neuroendocrine tumor. However, if you do have one of the following hormones listed below that is high, then you would quantify as a functioning pancreatic neuroendocrine tumors because those hormones will usually induce symptoms such as gastrin, insulin, glucagon, VIP, somatostatin, ACTH, parathyroid hormone, LH, and serotonin. These are all hormones that can be secreted by pancreatic neuroendocrine tumors that would induce symptoms and a clinical syndrome, and therefore these are quantified as functioning pancreatic neuroendocrine tumors. So that's really an important difference because patients always ask me, well, do I have a functioning pancreatic neuroendocrine tumor because my pancreastatin or my chromogranin A or even my pancreatic polypeptide levels are high? And the answer to that is no. That would not quantify as a functioning pancreatic neuroendocrine tumor because these hormones on their own do not cause any symptoms. So there are a few treatment goals for functioning pancreatic neuroendocrine tumors. The first one is that we would want to control the clinical symptoms. That can be done with medications, with surgery, and other therapies that are usually employed for all types of neuroendocrine tumors. And also, we obviously want to control tumor growth. Surgery, again, is the only potential curative option for localized functioning pancreatic neuroendocrine tumors. And all localized functioning pancreatic neuroendocrine tumors should be resected. If you remember my talk from last year, I talked a little bit about pancreatic neuroendocrine tumors and when should they be resected. And generally, you look at the ENETS or the NANETS guideline, we don't necessarily recommend to remove pancreatic neuroendocrine tumors when they are less than 2 centimeters. It's okay to observe them. But that only is the case if we're talking about non-functioning pancreatic neuroendocrine tumors. Functioning pancreatic neuroendocrine tumors should be removed most of the time, maybe with the exception of gastrinomas, because they cause usually high hormone levels and also they cause symptoms. What type of surgery? We talked about that last year, if you remember well, but essentially what this is just depending on where your tumor is, you'll get a Whipple operation, you'll get a enucleation, or you will get a distal pancreatectomy. This is all the relationship of your tumors to the main pancreatic duct, the common bile duct, whether it's in the head, the body, or the tail. But it is acceptable for functioning pancreatic neuroendocrine tumors to be enucleated, so removed without resecting a major part of the pancreas. All right, let's talk about the different tumors for the next few minutes. So first of all, let's talk about insulinomas. A vast majority of them are benign, meaning they don't tend to spread very often, but they can be associated with a rare genetic syndrome called MEN1. The symptoms of insulinomas are not subtle. I'm going to repeat this one more time. Usually you have an extremely low blood sugar, less than 50. You have a high insulin level in your blood and a high C-peptide level. The symptoms are often sweating, palpitation, syncope, sudden weight gain, confusion. And then the famous Whipple triad is that these three things, like fasting hypoglycemia, meaning when you don't eat, your blood sugar drops. Symptoms of hypoglycemia are the ones on the left here: palpitation, syncope, sweating. And then when you get a sugary drink, or when you drink orange juice, or you get a sugar pill, the symptoms get immediately better. Often the patients that have insulinoma come to me and told me that they passed out for no good reason, and that when the doctors or the medics checked their blood sugar, it was found to be really low. So again, insulinomas, if they are localized, should be removed with surgery, no question. If they are not localized, or if the blood sugars are really low permanently and it's causing a lot of issues until patients undergo surgery, there are some medications that can be used, such as diazoxide, octreotide, or calcium channel blockers. And then when they are metastatic, so when the tumors has spread, which is very rare with these type of tumors, but the usual treatment algorithm for metastatic neuroendocrine tumors comes in, so PRT, sunitinib, and perhaps everolimus plays a particular role, because everolimus tend to raise the blood sugar. So in like insulinomas, where your blood sugars are very low, it may be of advantage to be treated with that particular drug if you have metastatic disease. Gastrinomas have almost always a malignant potential. A quarter of them associated with this rare genetic syndrome called MEN1. You have to know, and I mentioned that a little bit before, that there's such a thing called the gastrinoma triangle. So gastrinomas don't necessarily originate within the pancreatic head. They could also originate in the duodenum, and that's the first part of the intestine. That's actually most commonly where they start. The diagnosis is done by measuring the gastrin level, which is very high, usually greater than 1,000 or 10 times normal fold. Again, not sudden in symptoms. Severe acid reflux, multiple stomach ulcers, GI bleeding, etc., are all part of gastrinomas. Surgery for localized tumors, again, and then medications. We can use proton pump inhibitors, which are basically like acid inhibitors, octreotide, and again, we use the usual treatment algorithm for metastatic tumors. Glucagonomas also have a high malignant potential. They are diagnosed by high glucagon levels. Again, I'm going to say this one more time, not a subtle tumor. If you have a glucagonoma, you're going to know, because you're going to have a severe skin rash most of the time. It's called necrolytic migratory erythema. There's an example here on the right side. You're at higher risk to develop blood clots, and you have high sugar level because glucagonoma is the antagonist hormone to insulin. And so your sugar level will be very high. Surgery for localized tumors, medications used to control symptoms, insulin, like other diabetic drugs to lower your blood sugars, blood thinners, and also octreotide. And then again, we use the usual treatment algorithm for metastatic tumors. VIPomas, also very rare tumors. They're called, or if you do have a VIPoma, you have the Werner-Morrison syndrome. 100% malignant potential. VIP levels are usually greater than 75. Again, not subtle, massive watery diarrhea, low potassium, low chloride levels. I know at least of one person that has had a VIPoma, and if you talk to that person, that's a strong patient advocate. He will tell you that the massive watery diarrhea is really what defines VIPomas. Surgery for localized tumors, medications, octreotide, IV hydration, because you lose so much water through the watery diarrhea, as well as alpha interferon can be used. And again, the usual treatment algorithm for metastatic tumors. ACTH-producing tumors, even less common. So it's a form of ectopic Cushing's syndrome. Those, again, are very blunt and obvious symptoms. Moon phase, buffalo humps, striae, new onset diabetes, new or worsening hypertension, osteoporosis. All of these are due to the fact that ACTH is a hormone that tells your adrenal gland to produce massive amount of cortisol. As I said before, all of these things that you can see on the right side that cause like Cushing syndromes are not subtle. It's not something that most of the time clinicians would miss. Again, surgery for localized tumors, medications can be used to control the hypercortisolism, and occasionally, in addition to all the usual treatment algorithm for metastatic neuroendocrine tumors, we sometimes remove both of the adrenal glands because that's, again, the source of the high cortisol level. And if you remove both of them, then there's no more cortisol produced in the body, but it also means you would have to take cortisol in addition because you need at least a little bit of cortisol to live. Lastly, serotonin-producing tumors. Again, I want you to remember that's very rare when it comes to pancreatic neuroendocrine tumors. Far less than 5% of pancreatic neuroendocrine tumor produce serotonin. Serotonin is most commonly produced by small bowel neuroendocrine tumors and small bowel neuroendocrine tumor patients with liver metastases. The symptoms include flushing, diarrhea, wheezing. Here you can see a patient with flushing on the right side in her face. The flushing, the diarrhea, and the wheezing are usually consequence of vasoactive peptide secretions. And the high serotonin level can also cause problems with the heart valve, especially the right heart valves. The medications are the same that we use for small bowel neuroendocrine tumors, which are basically octreotide and Zermello, are two drugs that can control serotonin levels and diarrhea. And then when you have metastatic neuroendocrine tumors, again, we use the usual treatment algorithm. And by that, I mean this here, which is, if your tumor has spread on the right side here in red, then you may want to consider surgical debulking, which has a specific role for functioning neuroendocrine tumors and also functioning pancreatic neuroendocrine tumors if they have spread, because none of the systemic therapies except for octreotide has robust data, so that there are a lot of trials, because these tumors are so rare, to show that these other drugs can really consistently control symptoms. There are some studies that are small studies where PRT and like everolimus have been shown to control certain symptoms of these functioning pancreatic neuroendocrine tumors when they have spread. But again, they are rare, these tumors overall, so the data is not quite there yet. We certainly need to do more research there in the future. So I hope this was helpful. Please do not hesitate to reach out in the Q&A if you have any questions regarding functioning pancreatic neuroendocrine tumors. And then my email is also there on the right hand side. So email me if you have any further questions. Thank you very much for the opportunity to speak today.